our next speaker before, but I'll tell you, I think we're in for a great treat, just based on the conversations that I've had with him. And to say his name, I'm going to say Dr. P. Is that okay, Greg?
Yes.
All right.
It's pronounced Pokrywka.
Pokrywka, okay. Comes to us from Johns Hopkins University School of Medicine, director of the Baltimore Medical Lipid Clinic, fellow of the Lipid Center, but this one I found interesting, certified menopause practitioner. Now, when we asked Greg to come, he graciously accepted. He thought he was going to have a fun night in Sacramento, and then, you know, it's not very easy to get to Redding. And so had a tough time, came in late last night, and we have to find him a ride back quickly right after his lecture so he can make his flight back to Baltimore another 7 hours. That's a long, quick trip to come to Redding, but we truly appreciate it. Hopefully, it will make a difference for us and for our patients. Thanks, Greg.
Let's see, how do we advance the slides? Let's see. Okay.
This one advances it.
That's advanced.
You can scroll back.
Okay, and the pointer is that way.
Mouse.
Okay. Good morning, everyone. Thanks for having me here. I have two disclosures. I am a statin user, but I have reduced my caloric intake since I've been on a statin. Second, I get lots of leisure time activity, including I'm an avid runner and sea kayaker, and I hope to be in the waters of the Chesapeake Bay tomorrow. So thank you very much for having me. Dr. Kopecki's talk was unbelievable, tough act to follow. I hope I can only be half as entertaining and half as informative. Menopause practitioner, there's something called the North American Menopause Society. We don't have any menopausal ladies here, I don't think, but we'll all get there, hopefully, right? Or you all will get there. And NAMS is really the leading society for the study and care of menopausal women in the world. And things change when you get to menopause, girls. You know, there's more insulin resistance, there's more cardiovascular disease. I think we have a talk on women and cardiovascular disease later this morning. But Women Are Not Small Men is the title of a very famous book. So you guys have a different physiology than us. You have smaller coronary arteries. Even when you adjust for BMI, you have those coronary arteries are more responsive to the classic risk factors like smoking and high triglycerides and hypertension, et cetera. So, you know, menopausal clinician, that's what it is. Some of you may have heard of the National Lipid Association. Our website is at the bottom. It is lipid.org. If I can figure this thing out, let's see. It's very sensitive. There we go. Lipid.org is the National Lipid Association. You can become a member for $150 a year. You can become a board-certified clinical lipidologist with a lot more study and a little bit more money than that. There are about 1,000 of us in the world who are board-certified. We have nurse practitioners, PAs, dietitians, pharmacists, a very eclectic bunch of people who are board-certified as clinical lipidologists. So let's wade into this. Doctor to patient, I got some bad news. While your cholesterol level has remained the same, the guidelines have changed. Boy, has this been the last couple of years of guidelines, right? We've got way too many guidelines. We, at the National Lipid Association, have resisted adding to the fray and coming up with our own guidelines. We were sort of forced to in response to the flawed ACC-AHA guidelines, which we'll talk about this morning. But we call ours patient-centered recommendations, not guidelines. So. Wait a minute, we don't want to right click, we want to left click. Okay, so I promise I won't read too many slides, but I'll just read one statement from this one. This is the editorial that accompanied the new ACC-AHA guidelines when they came out in 2013. And it said, Jennifer Robinson, chief author, said, meta-analyses now provide extensive evidence that statins reduce cardiovascular events and total mortality. Anybody feeling a little old here this morning when we talk about events? You know, I remember when an event was tickets to the Rolling Stones concert, you know. Now we're talking about heart attacks and strokes. In individuals at lower risk of cardiovascular events, than has previously been appreciated, and do so with an excellent margin of safety. We all have patients coming into our office with reams of information on the internet saying, I don't want to take a statin, this blah, blah, blah guy says they're bad and such. There's an ex-astronaut that wrote an unreadable book called The Statin Crisis. Some of you may have run up against it. But the statins are kind of like the New York Yankees and Duke. They've been successful for so long, there's a big, big backlash against them, but that doesn't mean that they don't work. Recent statin meta-analyses provide evidence that largely refutes the major criticisms against statins used for primary prevention. We now know that statins work in primary prevention. We know that statins work in primary prevention in women. There are still those out there making that a controversial issue, but we know that the statins work. The Jupiter trial, among others, showed us very nicely that statins work for primary prevention in high-risk women. Accumulated evidence should convince those with a philosophical aversion to statin therapy for primary prevention to reconsider their stance. There are a lot of people out there that have philosophical aversions to any drug use. Our patients are confronted on a daily basis with various alternative medicine practices and basically what I like to call magic and witchcraft salesmen who are trying to convince them that all pharmacologic products are bad. But the statins have done their homework. They work. They have a very important role in what we do. Clearly, many more adults could benefit from evidence use-directed use of statins in primary prevention. There was an outcry when these new guidelines came out because people said, well, they want to put everybody on a statin, and that's certainly not correct. We want to put the appropriate patients on a statin because we know they work. So here's the big deal here, the 2013 ACC AHA cholesterol guidelines. What they did, this committee was empowered with the task of sifting through randomized clinical trial evidence and coming up with a decision as to who would benefit from a statin. What does the randomized clinical trial data show? And they use exclusively randomized clinical trial data, which is one of the big problems with these guidelines. We'll never have a randomized clinical trial for everything. What do we do with a 30-year-old? They haven't been studied in randomized clinical trials. What do we do with an 80-year-old? They haven't been studied either in most trials. So we're forced with either limiting ourselves to randomized clinical trial data or perhaps extending it with other sources of data and information. Now, randomized clinical trials are great. We need them, right? That's what separates us from Dr. Oz and various other TV charlatans and other purveyors of alternative medicine and integrative medicine. There are types of practices in this country that we're practicing not based on randomized clinical trial evidence. And there's a lot of practitioners in this country treating patients based on anecdote. And anecdote is not evidence necessarily. So we've got to have randomized clinical trials, but they're not enough to cover every situation. We have to extend the data. And that's what we've done at the National Lipid Association. So, here's the big set of guidelines. As we said, they were evidence-based. They eliminated targets. So we no longer have targets in the 2013 guidelines. What we have is we have 4 groups of patients where we know that statins work. If you're in one of these groups, you go on a statin. Does not address combination therapy at all. There isn't as much data for combination therapy in randomized clinical trials, so a lot of this was left out of the guidelines. And the following are no longer considered appropriate strategies. So we're not treating patients specifically to targets anymore. Now, this is a little confusing because even though we don't have specific cholesterol targets anymore in these guidelines, we do say that we want to put patients on high-intensity statins, and what does high intensity mean? It means we want a 50% reduction in LDL cholesterol levels. So you do follow-up monitoring of your patients under the new guidelines. Neil Stone is very sensitive to this issue. He's the author of the 2013 guidelines, and he gets beaten up all the time by people saying, well, you're discouraging follow-up monitoring. That's not what it's saying at all. We've just shifted our emphasis from a numerical target to a 50% reduction in LDL cholesterol in high-risk groups. Now, true evidence-based medicine. You can define evidence-based medicine, multiple definitions. I think this is the best. Evidence-based medicine is the conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of our individual patients. Yes, this incorporates randomized clinical trial data, but it also incorporates basic science. You, the doctor, should treat each and every individual patient in a manner you deem most appropriate. You're going to have to make decisions about patients that we have no randomized clinical trial data for. And you're going to use science and common sense in your judgment on how to treat those patients. So what was the feedback on these new guidelines? Generally, academics and types who believe in the status quo said it was simpler, more evidence-based. You are treating the right people. We're incorporating stroke. You know, these are the good parts of the guidelines. Generally, pretty negative reaction from the lipidology community. You remember, these are cholesterol guidelines. We got another big lipid out there called triglycerides, which are very important in risk diagnosis and risk prevention. There aren't any targets. There wasn't. We were ignoring non-statin drugs. Maybe it was too evidence-based. National Lipid Association did not endorse these guidelines, nor has the American Association of Clinical Endocrinologists. Lipoproteins and abnormal lipoprotein trafficking, that's what really causes atherosclerosis. It's one of the big risk factors, and it was largely ignored under these new guidelines. We ignored residual risk in statin patients. You know, you could put everybody on a statin, but your residual risk is still high. Statins prevent maybe a third of events, maybe 45% in a trial like the Jupiter trial when you pick the right patients. But what about the rest of those patients? I want everybody. I want all my patients' heart attacks and strokes prevented, not just 50%. The new guidelines, the ACC-AHA guidelines, ignored expert opinion and clinical expertise. Generally negative reaction from the public, a lot of conflict of interest. You look at the people on these guideline committees, many of them have pharma connections, et cetera. There was backlash, maybe too many people are going to be put on statins after these guidelines. So there was a lot of negative backlash. So what are we to do? What's a girl to do when faced, or what is a guy to do when faced with these guidelines? This is my main kayaking buddy. So let's go back and look at this whole situation again afresh. What actual lipid levels do we see in people having events? This is a study called Get With the Guidelines. These are people who have had a clinical acute event. The mean LDL cholesterol was 105. Doesn't sound too high, does it? Not at all. I mean, how do we see people with 105 LDL cholesterols all day? How do we know who to push, who to treat aggressively? It doesn't seem like a very high number. And as you can see, there's a tremendous amount of overlap. You got some of your FH patients way out here with LDLCs above 200 and such, but just look at the tremendous amount of diversity here in LDLC levels in people having an event. So I promise this is the most complicated slide we have, so I put it in early. Let's review lipid and lipoprotein metabolism. Remember, fats, cholesterol and triglycerides cannot just circulate in the bloodstream. Oil and water don't mix, right? They have to be packaged into lipoproteins to get anywhere. So when you eat, you absorb free cholesterol. Triglycerides are broken down into simple sugars and mono and diglycerides. They're incorporated into chylomicrons, the first lipoprotein vehicle. These chylomicrons are acted upon by lipoprotein lipase, the chewer, which breaks them down into remnant particles. These remnant particles are then further broken down to liberate triglycerides, which are fuel and which are structural components of adipocytes. Free fatty acids, again, used as fuel. Then the remnant goes back to the liver. Now, a high-fat diet is going to make more chylomicrons. So if you see someone with chylomicron disease, triglycerides of 2,000, 3,000, 5,000, you put them on a low-fat diet to minimize absorption. That's the dietary intervention you're going to use for very high triglycerides, above 500. When these remnants go back to the liver, they are reincorporated, the lipids are liberated, reincorporated into a VLDL particle. Excessive VLDL particle production is the mechanism and the underlying pathophysiology behind many of our triglyceride disorders where the trigs are in the range of 200 to 500. Oral estrogens, for example, increase the output of VLDL particles from the liver. Insulin resistance, having a breakfast every day like what we saw outside, high in simple carbohydrates. Please have protein with your breakfast every day. I had to go ask for some special order protein for mine, and I know protein is expensive, so that's why we don't have it at these symposia, but please don't eat like you eat at these symposia. Most of us view symposia as times to get out and party and eat junk and other things anyway, right? This isn't how we eat every day. But insulin resistance, too many simple carbs, you're going to get more VLDL particles. Again, these are going to liberate by the action of lipoprotein lipase triglycerides, which break down into fatty acids for fuel. Now, VLDL particles are very transient. They're broken down to LDL particles, which have a half-life of about 3 days, maybe as long as 5 days when you have insulin resistance. Too many LDL particles, you die faster. Can't be said enough times, and we'll say it several times during this talk. LDL particles are the primary ApoB containing abnormal atherogenic lipoprotein in the bloodstream. Too many LDL particles, you build plaque faster, you have more clinical events. LDL particles, the IDL particles are transient, they break down into LDL particles. these should go back to the liver and bind at the LDL receptor and be removed from the bloodstream. When we have too many of them, some of them will get into the arterial wall where various receptors will incorporate them into the cholesterol pool and you'll get plaque buildup. Many of the pharmacologic strategies we use to lower LDL particle counts upregulate LDL receptors. That's what the statins do. That's what colesevelam does. That's what ezetimibe does. The PCSK9 inhibitors, a new class of drugs which will hit home very rapidly, probably by Labor Day. These drugs inhibit the degradation of LDL receptors. More LDL receptors is good. We're going to suck more LDL particles out of the bloodstream and prevent them from getting into the arterial wall where they cause havoc. Now, what happens with HDL metabolism? Most HDL is made in the liver. About 30% is made in the gut. HDL starts out as a naked, sort of dead bug-looking like thing. ApoA1 is the major structural component of an HDL particle. These guys go into the arterial wall, bind at ABCA1 receptors, and here's where you get the real dead bug-looking thing. Here are the initial discoidal or pre-beta HDL. This is the first HDL particle. It goes back in over and over again, picking up more and more cholesterol, which is esterified by LCAT. Then it unfolds into a mature spherical HDL particle. These guys take cholesterol back to the liver in a process known as reverse cholesterol transport. In between, you'll get an interchange through the action of an enzyme called CETP. You'll get an interchange between cholesterol and triglycerides with these triglyceride-rich VLDL particles. CETP inhibitors are out there being studied in clinical trials now. If you inhibit CETP, you make a bigger HDL particle, hopefully making more reverse cholesterol transport. These clinical trials are underway. We should have results within a few years about that. So why do we have HDL in the first place? Not to protect ancient man from atherosclerosis. He didn't get it, right? He didn't have these excessive cholesterol pools. So HDL really exists to take cholesterol to the steroidogenic tissue so we could make corticosteroids, so we can make estrogen, so we can make testosterone, as we just talked about. So HDL will bind at receptors called SRB1 receptors, liberate cholesterol back into the liver where it's excreted out into the bile. Anything that promotes this process of reverse cholesterol transport should prevent atherosclerosis. We don't have great HDL raising or HDL functionality increasing drugs. Niacin has failed us time and time again and is falling in its use. Fibrates, interestingly, promote reverse cholesterol transport through increasing the efflux right here, increasing the manufacture of HDL particles, increasing this whole loop. So fibrates are a very interesting alternative we have in 2015 to improve reverse cholesterol transport. As you can see, we could spend a whole talk on this slide, so let me get out of it. Here's a great-looking slide for those going out to eat tonight, right? This is not what you want to see. How does the cholesterol get into the arterial intima? As we said before, lipids don't circulate freely in the bloodstream. They have to be packaged into lipoprotein vehicles. Here are the lipoprotein vehicles. The bad guys all have this ApoB, snake-like moiety on them. They, when produced in excess, or when they're not cleared from the bloodstream fast enough, they will get into the arterial wall, make foam cells, and you'll get plaque buildup. You'll get clinical events. We talked about HDL metabolism a little bit in the last slide. So the subendothelial lipoprotein retention is the initiating process in atherosclerosis. You have more bad particles, you're going to get more plaque formation. It's that simple. More LDL particles, more clinical events, greater mortality, etc. The probability that a particle's cholesterol will be delivered to an atheroma depends on particle number. We need to figure out a way for each of you in your practice of medicine to count LDL particles. When a patient comes to you and says, how am I doing? What is my risk? We can't just rely on an LDL cholesterol to tell them their risk. We need to find a way to quantitate LDL particles. Now, here's the LDL particle, public enemy number one. ApoB is the spaghetti noodle-like type protein that wraps around the outside. There's a one-to-one relationship between ApoB and the number of atherogenic LDL particles. Think of the LDL particle as like a dump truck. Too many dump trucks dumping off cholesterol junk into your arterial wall. How do you count dump trucks? Every dump truck has a license plate. We know it as ApoB. Average ApoB in menopausal women and people, males above 50 is probably about 95 in this country. Hunter-gatherers have ApoBs of 50 or less. They don't get atherosclerosis. When they're 70 years old, they die of something else, such as a degenerative disease or being unable to run away from predators fast enough, whatever else. But they don't get atherosclerosis. We get atherosclerosis because we make too many ApoB particles. How do we assess LDL? We know LDL is bad. When I'm a biochemist by training, and around 2000 or so, when the first techniques came out to measure LDL size, I was really intrigued. I thought, this is great. And we know there's an association between small LDL particles and increased cardiovascular risk. We now know, though, that particle size drops out as a predictive factor when you take into account particle number. So particle number is much more important than particle size. There are laboratory companies out there offering particle size determinations. It's nice. Usually people with small particles are insulin resistant, so you can use that in helping you to guide their nutritional and lifestyle modification. But it's really all about particle number. That's what you need to do. You need to find a practical way in your practice to count particles, and we're going to give you a couple tools to do that. LDL cholesterol is just the cholesterol component of an LDL particle. You know, if you've got all these bad dump trucks in your bloodstream, you can count the amount of cholesterol in them. That's your LDL-C that you get in the standard lipid panel. But that is a lousy predictive factor as we age. It's a lousy predictive factor when you're insulin resistant. It's a lousy predictive factor when your trigs are much above 100. We're going to define what non-HDL is in a few moments. We mentioned what ApoB is. And LDL particle count is, there are several different methodologies out there to count LDL particles. The one with the most evidence-based clinical data is the NMR technique. Okay, this is the only one I know of that has published clinical trials that show us that it is superior to lipid determinations in terms of correlation with disease and in terms of correlation with events. So for my money, the NMR technique is the one to use. Now, again, low-density lipoprotein particles can be characterized either by their cholesterol content, that's what we do in a lipid panel, or you can count the particles. Please don't confuse LDL-C. You know, we walk around saying things like my LDL is 100. What we usually mean by that is our LDL cholesterol is 100 milligrams per deciliter. Realize LDL particle count's completely different terminology. Why is this important? You can have patients who are insulin resistant who have a low LDL-C. Their LDL-C could be 70, but they could still be swimming in a bath of atherogenic LDL particles. And unless you count them, you're not going to know that. The reverse is true. We see young women who come in and have LDL cholesterols of 130, 140. Their primary care provider wants to put them on a statin. We count their particle number, and it's low. And I say, you're fine. You don't need a statin. You don't need anything. Just keep doing what you're doing. The risk tracks more closely with the lipoprotein particle counts, not with the LDL cholesterol count. Very important point. What happens when your trigs are up? If your trigs are above about 100, such as we get with fatty liver, insulin resistance, etc., the trigs are going to be excreted from the liver as part of a normal defense mechanism to be excreted into VLDL particles. Okay? High triglycerides, much above about 100, 130 or so, you're going to get these trigs flowing down a concentration gradient into the LDL particles in exchange for cholesterol ester. So you're going to make a triglyceride-enriched LDL particle. That doesn't happen in hunter-gatherers, right, who have trigs less than 50 their whole lives. So in the Western world, where we eat too much, we have too much insulin resistance, and our trigs are high, we generate these triglyceride-rich LDL particles. They are laced by hepatic lipases to form small, dense LDLs. Guess what? They don't bind to the LDL receptors as well. They pile up in the bloodstream. What happens when you have a lot of LDL particles in your bloodstream? They get into your arteries, you build plaque, and you have events. So when the trigs are high, much above 100, you get decreased LDL size, and you get an excessive number of atherogenic particles. Same things happens on the HDL end of things. When your trigs are high, the trigs flow down a concentration gradient. They ride this triglyceride tsunami into HDL particles. Lipases act on these abnormal HDL particles enriched with trigs. You get a smaller, dense HDL. These guys are excreted in the urine much more readily. You lose your atheroprotective HDL particles. HDL particles are the good guys, right? They have antioxidant properties, anti-inflammatory properties. The more HDL particles you have, the better off you are. Okay, and you're going to lose these protective HDL particles. Your HDL cholesterol goes down. Everybody here knows when your trigs go up, your HDL cholesterol tends to go down, right? Okay, this is why, because you're making smaller HDL containers. They don't contain as much cholesterol. Some of them are being lost in the liver. So this is what we call the atherogenic dyslipidemia. This is the most common lipoprotein abnormality we see in America today. At least half our practices are insulin resistant these days, right? Trigs will be high, small dense LDL, too many LDL particles, smaller HDL particles, fewer HDL particles. HDL function is one of the next frontiers in the field of lipidology. The HDL cholesterol doesn't tell us anything about HDL function. You know, there are girls in this audience, I'm sure many of you have HDL cholesterols of 70, 80, 90. And that sounds pretty good, doesn't it? But that's only the cholesterol content of an HDL particle. It doesn't tell you about its functionality. Women with HDL cholesterols of 70, 80, and 90 still have heart attacks and strokes. You know, their HDL functionality might be poor. So don't, girls, just bet on a high HDL cholesterol protecting you from cardiovascular disease. LDL-C often fails to reflect the number of particles. Let's look at a clinical situation. I don't really have cases in my discussion today, but I have a couple right here. So a woman comes in and says, "Doc, my LDL cholesterol is 125. What do I do?" In this case, her triglycerides are less than 100. HDL cholesterol barely adequate for a woman. Okay, her non-HDL cholesterol, which is total minus HDL, was 143. These LDL particles tend to be big. Doesn't take many big LDL particles to carry that much cholesterol. This is a relatively low-risk situation compared with the next patient. Woman comes in, same identical LDL cholesterol, 125. She says, "Doc, what do I do?" Here, the trigs are elevated. You should get excited about a trigs of 250. Anything much above 100, I get excited about. HDL cholesterol, very low. You see a ratio here of trig to HDL cholesterol about 8 to 1. Any, if you want to write something down that I don't have in my talk, any trig to HDL ratio greater than 3 to 1 is bad news. Trig to HDL cholesterol ratio greater than 3 to 1, bad news. Usually you have a lot of small, dense LDL particles with that, and usually you have insulin resistance to one degree or another. So this young lady, non-HDL cholesterol much higher, 205 minus 30, takes a lot more small particles to carry the same amount of cholesterol load. So this is a much riskier situation, even though the LDL cholesterol is exactly the same. This is the core of this talk. You know, being able to look at patients with a given LDL cholesterol and evaluate their risk. This woman is at much higher risk because it takes a lot more atherogenic particles to carry that amount of cholesterol than it does in the other situation on the other part of the slide. Guidelines from ATP3 and the AHA guidelines typically call for these targets. Now, National Lipid Association, as I said, in response to the ACC-AHA guidelines, patient-centered recommendations. And this report is available online. I put the URL here. If you go to lipid.org, you can find them. Free download, great slides for talks. You don't even have to be a member to get these. So our guiding principles were that an elevated level of cholesterol carried by circulating ApoB-containing lipoproteins is the root cause. We call this atherogenic cholesterol. I love that term. I don't know if anybody's used it before, but we came up with it. So there's atherogenic cholesterol. Obviously, there's non-atherogenic cholesterol too, but how do you measure atherogenic cholesterol? We advocate using non-HDL-C and LDL-C. Certainly, you can use more sophisticated particle counting techniques, et cetera. But if I could get everyone in this room to start using non-HDL-C at least, we could certainly reduce the burden of atherosclerotic events dramatically. Reducing levels of atherogenic cholesterol is a goal. We want to reduce it in proportion to the extent that the risk will be reduced in proportion to the reduction of atherogenic cholesterol. So that benefit is presumed to occur through multiple modalities, including lifestyle and drug therapy. We have a heavy emphasis on both. The intensity of risk reduction should be in line with the patient's absolute risk for an event. We don't have a one-size-fits-all. You know, there's other factors that go into risk evaluations, such as hypertension and age. This is a process that begins earlier in life. Dr. Kopecky talked about primordial prevention. We firmly believe that we need to be checking lipid levels in patients in the first grade, and again, then in late in high school. You don't check lipid levels in adolescence, by the way, because the body composition changes that occur through puberty and such cause the levels to be unstable. But every kid in America should be checked at least in the first grade or so, and then again late in high school. I mean, that's how we screen for both common and rare disorders. Statins are the primary modality we're going to use in reducing risk. Non-lipid factors should be controlled. You know, when I as a lipidologist, get somebody's lipoproteins under control and see that they're blood pressure is still elevated, I do something about it. I want to control all these risk factors to the extent possible. So non-HDL I've talked about a little bit, but just to give you a visual of what it is and how important it is to you in your practice. It only takes a second to calculate. It's total cholesterol minus HDL cholesterol. If my total is 150, my HDL cholesterol is 50, 150 minus 50 is 100. You can do this. Many of you are getting it on, sorry, oh, how do I go back? Shoot.
Just scroll.
Just scroll. Oh, scroll. Let's see. Scroll up. Yes. So, sorry. Many of you can do this. Some of you are probably getting it already. The NLA is really trying to get every lab in America to offer a non-HDL cholesterol. But just take a second to do it. You know, the other guy down the street's probably not doing it. How many people in this room do non-HDL cholesterol routinely? I'd be curious. We only have a few of you. I would hope, as one of the realizations from this talk, that more of you would start doing it. Get people to non-HDL goal, get people to LDL cholesterol goal. Try to get people to both of these goals, and I'll show you what those goals are in a moment. But remember, non-HDL works as a better predictor of risk than LDL-C because it's a better marker. It correlates better with LDL particle count. So non-HDL-C is your free way to count particles. It only takes a second. It's not as good as an ApoB or an LDL particle count by NMR in clinical trials, but it's a lot better than an LDL cholesterol. So key new emerging risk factor for you to measure. We believe that we should use treatment goals. I'm not going to read this whole slide, but we believe that there are many reasons why we should get back to using treatment goals. They're useful to patients. There is evidence to support treatment goals. In the literature, there is evidence to support lower is better. We do not have clinical trials that address specific LDL-C and non-HDL-C goals. We may never have specific trials. A lot of our clinical trials are done by pharma. You put patients on a drug versus a placebo, you see what happens. We're not really designing trials to test specific targets. Nonetheless, we believe there is enough evidence and enough clinical utility that we've brought back targets in our patient-centered recommendations. So here's our patient-centered recommendations, very similar to what you saw in ATP3. We're trying to get our high, moderate, and low-risk patients to a non-HDL-C less than 130. We put non-HDL-C first because we believe it's a better risk predictor, and the data shows it's a better risk predictor than LDL-C. Here are our ApoB targets you may not be familiar with. As I mentioned, an average ApoB in America is about 95. We're trying to get our at-risk patients below 90. Our very high-risk patients, defined the same way as ATP3 defines it, people who are CHD risk equivalents plus have ongoing severe risk factors such as smoking or chronic kidney disease, et cetera. There's a whole long list. These patients we want to treat more intensively. Non-HDL-C less than 100, LDL-C less than 70, ApoB less than 80. So again, we're tailoring the intensity of our treatment to the amount of risk in the patient. Atherogenic cholesterol levels are the primary targets of therapy. Non-HDL-C is listed first. It's a better predictor of risk than LDL-C. Particle-based testing, ApoB, is optional. And there was a lot of discussion and argument about this among lipidologists, but we settled, when the dust settled, we said it was optional. I myself believe you really need to do an ApoB or an NMR-derived LDL particle count as an accurate assessment of risk in 2015. These technologies are available. They're often not covered by insurance, but they're not that expensive. ApoB costs about $55 at Hopkins. The NMR-derived LDL particle count is covered by every insurance in Maryland. So money really shouldn't be a barrier to get these tests. Why do we advocate these tests? Because they're more predictive than LDL-C. 40% of diabetic patients with an LDL-C under 70, 40% have an excessive number of ApoB particles and LDL particle counts. Docs say to me, well, I did these as advanced testing. I did it for a while. It didn't change what I did, so I stopped doing it. 40% of the time, it's going to give you the information needed to make a clinical decision. If I've got a diabetic CHD risk equivalent patient with an LDL-C of 70 and her particle counts are high, I'm going to do something. I'm going to increase lifestyle management. I'm going to maybe intensify their statin therapy. I'm going to add a fibrate, for example, or add another drug. It's going to give me the power to do something when I know what's going on with that patient. And here are the optional goals for ApoB, as I mentioned. LDL particle concentration. Every lab is now coming out, or multiple labs are now coming out with LDLP determinations. There's colorimetry methods. There's Dr. Krause's method here in California. The only one that I know of that has been clinically validated and shown to be superior to lipid measurement is the NMR technique. There's thousands and thousands of patients in clinical trials in which we've tested the NMR-derived LDL particle count and shown that it's superior to lipids. So that's what I do. Now, targets of therapy, TRIGs. TRIGs are the forgotten lipid. We do not have a clinical trial that says lowering triglycerides reduces risk. We have trials underway, the STRENGTH trial by AstraZeneca and the REDUCE-IT trial by Amarin. So we have trials underway testing the hypothesis that lowering TRIGs prevents events. But I want you to pay attention to TRIGs. You know, TRIGs are a marker of disordered lipoprotein trafficking. They're a marker in the United States usually for insulin resistance. So when your TRIGs are above 100, start thinking about those two disorders. When your TRIGs are above 500, treat them immediately. Risk of pancreatitis is high. You can die from pancreatitis in one weekend of going out and partying and drinking alcohol or eating a lot of fats and sugars and such. So when your TRIGs are above 500, you got to do something. You know, usually we're going to initiate either high-dose omega-3 therapy, 4 grams a day, pharmacologic omega-3 therapy. My preferred method is the icosapentaethyl ether esters that are made by one pharmaceutical company. So the prescribed prescription high-dose omega-3s are what I would use, and or a fibrate in these patients. So TRIGs above 500, chylomicron disease, low-fat diet, start pharmacologic therapy immediately. When TRIGs are between 200 and 500, they're not the target. We don't have evidence to support that yet, right? So what you do is you target non-HDL-C, you count particles, you get those particle counts down. That's a target. I'm not out to make everybody's TRIGs below 100. If somebody's TRIGs are 179 or 279, you know, I'm out there to reduce their bad particle counts. That's our goal in those patients. We do have excellent genetic evidence now, and I'm not going to go through the details of this slide, but we now know that when you have a genetically abnormal elevated triglyceride level, this correlates with cardiovascular risk. We have the same kind of data for abnormalities of LDL, right? When you have high LDL particle counts due to FH, you die faster. We don't have that kind of data for HDL, do we? It's been a bad couple of years for the HDL cholesterol hypothesis. HDL cholesterol mutations that cause increases in HDL cholesterol don't necessarily cause reductions in events. But we have great evidence now that genetic high TRIGs, genetic high LDL are associated with increased numbers of events. So we need to pay more attention to triglycerides. HDL cholesterol, we're going to be laughing, I think, 20 years from now, maybe 10 years from now, that we ever paid attention to HDL cholesterol. Drugs that raise HDL cholesterol don't prevent events. If we look at lipoproteins as trucks transporting cholesterol throughout the body, HDL would be like a super complex fire truck putting out fires with lots of hoses and nozzles and proteins on the outside. It's a very complex entity, and the cholesterol component of HDL is only part of the game. You know, you say your HDL is 60, that's the cholesterol content. It tells you nothing about the function of that HDL particle. We need better ways to assess HDL function. We need better ways to count HDL particles. I use the NMR technique. More HDL particles, better. Okay, better functionality. And we'll see what happens. There are some HDL increasing drugs, HDL function increasing drugs under development. We'll see if they work. Very high and higher, very high risk patient groups. Here's the definition. Remember, chronic kidney disease, stage greater than 3B, your cardiovascular risk goes up. We're getting a lot of these patients now as we get an aging population. Criteria for classification of ASCVD. Some of these slides I just put in here for your edification and future reference. I'm not going to go through the whole algorithm of ASCVD risk assessment that we advocate at the NLA, but the 2013 ACC-AHA guidelines immediately start with a risk calculator. We don't do that. We recommend that you count risk factors. We've got all the classic risk factors in here. If you get 2 or more risk factors, then you use risk scoring. So we're not advocating a use of the calculator immediately. That's a big difference between our patient-centered recommendations and the ACC-AHA guidelines. Again, very complex slide, but our targets, again, are to get the non-HDL down to 130 in most patients, always starting with lifestyle, then using pharmacologic therapy. For very high-risk patients, here's how we define them. We're using lower, more intensified targets, non-HDL below 100 and LDL-C less than 70. There are other risk factors that can mitigate and might be considered for risk refinement. Many of us here are doing inflammatory markers such as HSCRP or LPPLA2 or myeloperoxidase testing. HSCRP is our patients are coming in and seem to have an awareness of it. There's many popular articles about it. It's useful in populations. I'm not as sure if I really believe it to be useful in individuals, as it's so highly variable. If I go out for a run in the morning, I'm sure my hs-CRP goes up because of low-grade inflammation in my aging 58-year-old joints. So hs-CRP is a very soft risk factor, I think. In populations, it's important. I'm not sure that I use it much in individuals. Lp(a), we don't have time to talk about, but Lp(a) is the most common genetic cause of premature and familial events in America today, and we're developing better and better ways of measuring Lp(a). We can now count Lp(a) particle counts, and this is probably a better predictor of risk than Lp(a) mass, which is the traditional thing. So Lp(a) is just a modified, nastier LDL particle. Tends to go up after menopause, unfortunately, the levels of this, because estrogen seems to keep the levels down. Drug therapies. Patient-centered therapy. You have to have a dialogue with the patient and discuss their risk, discuss the options. We're past the day of just the doctor telling the patient what to do. It has to be a dialogue. When pharmacotherapy is used, we advocate use of moderate or high-intensity statin therapy. I get people coming in and they say, well, I'm on 5 milligrams of simvastatin. What's this doing for me? Has anybody ever studied that in a clinical trial? No. We don't, we know what it does for lipid reduction. We've never really studied its effects. And some of the effects of statins go beyond lipid and lipoprotein reduction. So if you're going to use a statin, use moderate or high-intensity statin therapy, as long as the patients tolerate it. And that's a big if that we can talk about if we have time. Triglyceride reduction, we're emphasizing trigs, paying attention to trigs, and treating trigs when they're above 500 right in our patient-centered recommendations. The ACC guidelines do not have these in there. Trigs above 500, you need to do something, usually starting with diet change, high-dose omega-3s, plus or minus a fibrate. Statins can be used as really a tertiary or secondary drug for super high trigs. We're trying to get our atherogenic cholesterol levels, or ApoB or NMR-derived LDL particle count levels, below the goal cut points. I mean, that makes sense. The patients who do the best job of doing this in my practice are the ones that incorporate targeted lifestyle change as well as pharmacologic therapy. You got to do both. I'm fortunate I have a dietitian in Lipid Clinic who works with all of my at-risk patients, as many who are willing to come in and work with her. And I would urge you to find and use a good clinical dietitian, preferably one who's also well-versed in lifestyle change, such as exercise also. One last thing on that last slide. Patients come in and say, is my LDL cholesterol too low? Is there a lower limit here? There really is no evidence yet. There are rare diseases where people have very low cholesterol levels in their entire lives. And keep going back, sorry. And what do these patients suffer from? They suffer from longevity. They live a long time. They have Methuselah syndrome. That's the name I was looking for. So they need to get nursing home insurance. That's what I tell them to do. But we really don't have a level that's too low. With the new PCSK9 inhibitors, where we're routinely getting very low LDL cholesterol levels, they're doing studies to see if there's any harm from this. And so far, so good. Combination therapy. We, in our patient-centered recommendations, advocate combination therapy when you can't get a patient to target with lifestyle and a statin. There is evidence in diabetics, for example, if you add a fibrate to diabetics who have trigs around 200 and a low HDL cholesterol, you add a fibrate, you get a 30% event reduction. So there's good evidence out there. No evidence for combining niacin with anything, so we rarely use niacin anymore. Got great data for ezetimibe from the Improve It trial that came out in the fall, so we know that ezetimibe reduces events on top of a statin. We've got LRC data from bile acid sequestrants, not exactly colesevelam, but a medicine in the same class. So we do have evidence, contrary to what the ACC AHA guidelines say, we do have evidence that combination therapy works, and there are more trials underway, particularly with high-dose omega-3s, for example. We already have some evidence from the JLIS trial. When you add 2,000 grams of EPA to a statin in Japanese women, you get significant event reductions, particularly when the trigs are high. FH is one of my favorite things to talk about. We could do a whole other talk about that next year or some other year if you want, but 1 in 350 Americans has FH, familial hypercholesterolemia. Every elementary school in America has a kid, on average, with FH. If we don't screen for them, we don't find them. That's the best primordial prevention you can get. So that's why we advocate lipid screening in the first grade. If your parents have risk factors, we can recommend it at age 2. Can you imagine the outcry that there comes from parents when you talk about screening their kids for lipids when they're 2 years old? They're saying, oh, these big bad pharma guys want to put us all on a statin. Well, if my kid is 2 years old and has FH, I'd probably want to put him on a statin. Maybe not 2. You could make a case. We have statin safety data down to age 8. But, you know, we have data that statins are safe in very young children who have FH. The disease is worse than the treatment, certainly, by far. So FH, we could talk about that more in Q&A if we have time. So what do we do now? I'd recommend using the National Lipid Association patient-centered recommendations for management of dyslipidemia. I think they offer significant advantages over what we have from the ACC, AHA. Use pathophysiology. Apply lipoprotein goals above and beyond lipid goals. Just because someone's lipids are normal doesn't mean that you've diagnosed and effectively treated abnormal lipoprotein trafficking, particularly if they're insulin resistant, which is an epidemic in America. At least do a non-HDLC. Make sure they're at goal from that. Don't attempt to raise HDLC, particularly with niacin. This is a failed strategy. I don't care what my HDLC is. I want to know what my HDL particle count is. I want to know what my HDL function is. That's much more important. As I said, fibrates seem to increase HDL functionality with very minimal increases in HDLC. Trigs are your primary target only when they're above 500. Somebody comes in with trigs of 2,000, get those trigs down. Start lifestyle and pharmacologic treatment immediately before they get pancreatitis. And if you're going to use statins, use either moderate or high-intensity statin therapy. These are proven effective doses. I use imaging studies for my intermediate risk patients. I'm a big fan of carotid IMT. It's a non-radiation technique you can easily do in your office. It's been clinically validated. My carotid IMT is abnormal. It's been abnormal since 2003, but it's stayed the same. I'm 12 years older now. My carotid IMT is the same. I've slowed the progression of my disease with intensive lifestyle change and high-intensity statin therapy. Coronary calcium scoring is okay, but involves radiation. You have to go to the hospital. There's no serial data looking at it. When it's studied in serial fashion, I'm not as high on it. You can do it as a one-time life assessment if you want. Markers of inflammation, some evidence to support them, particularly the LP-PLA2 test. Remember that guidelines are a foundation, they're not a ceiling. You know, you can certainly go above and beyond the guidelines, but the guidelines should be viewed as a minimum. We need at least to measure non-HDL in everyone. What about LDL particle count? What about these new guidelines? Whenever there's a disagreement between LDL cholesterol and LDL particle counts, always the disease follows the particles. This is true in every study and every language. I mean, there's never been a study that shows that LDL-C is superior to LDL particle counts. If you've got access to LDL particle counts, please use them. They're particularly useful for patients in secondary prevention, patients on statin therapy, patients who are insulin resistant. It is compatible with the new guidelines. Certainly, once again, you can always go above and beyond new guidelines. I'm going to skip over that. Oh, I did want to show you, finish up with this. How are we doing on time? We're doing okay? Okay, a few more slides and we'll be done. Now, what about in the real world? We talk about cholesterol management versus particle management. I was part of a study where we looked at this Health Core Integrated Research Database, looked at about 16,000 high-risk patients. We looked at 2 different strategies, management to LDL cholesterol target and management to LDL particle target. You know, which group did better? Whoop. We're not advancing now. Guys, any idea? Just scroll forward. Let's see. Take us back. Here we go. So, what we saw in this study, the risk of a CHD event increased by 4% with each 100 nanomole increase in LDL particle count. In other words, more LDL particles, more risk. This is what we already thought. This national sample of commercially insured high-risk patients was used to evaluate 2 objectives. We wanted to look at the frequency of events to see if they correlated with LDL particle thresholds, and we wanted to compare risk reduction. We wanted to compare the incidence of events when we looked at low levels of LDL cholesterol versus low levels of LDL particle counts. And here's what we saw. The patients who had LDL particle counts, the proportion of patients with low LDL particle counts who didn't have an event was higher. Boy, that's a lot of double negatives, isn't it? The better way to phrase this, if we got patients to a low LDL particle count level, they had fewer events than if we got patients to a low LDL cholesterol count. So it made sense to use LDL particle counts as a target rather than LDL cholesterol. That's the best way to look at this. So this is our first really real-world data showing this. This is the first study to look at the association between LDL particle counts and CHD stroke events in a large-scale real-world environment. So these differences in lipids and therapeutic management were associated with significantly better control of all components of the standard lipid panel. Again, it shows you that in a real-world setting, managing patients to a lipoprotein goal is superior to managing patients to a lipid goal. In a day and age where cost effectiveness is of paramount importance, here's a really good study showing us that you have to spend a few extra bucks to do particle measurement, but it seems to pay off in terms of reduction of clinical events. Future considerations, I made this slide up last night after I got here. Here come the PCSK9 inhibitors. We're going to be deluged with information about this. Their PDUFA date, FDA approval date is June 24th, 25th, something like that. Going to have a couple of new drugs out, a couple of very powerful new agents to reduce LDL particle counts. All indications are that these drugs not only reduce LDL particle counts and LDL cholesterol, they reduce clinical events. They appear to be very, very safe. They're going to be indicated initially, we believe, on top of statin therapy. Statins will remain the bedrock. So for people who can't get the goal, we'll have these new tools. They lower LP(a) mass and LP(a) particle counts very well, and will probably be a new useful tool for that. Other uses, patients who are statin intolerant. What do we do with the incredible percentage of patients in our practice who seem to be statin intolerant? The usage trials showed this might be 20% of your patients. And because I run a lipid clinic, I get everybody else's patients who can't tolerate statins. So it seems like every patient who walks in to see me. But now we're going to have another very powerful tool. These aren't statins, so you can't have muscle aches and pains from them. I used to think a lot of the statin intolerant patients were wacky. Now I think that some of them are wacky, not all of them. We actually, in one of the clinical trials I participated in, we tested people. To get into the trial, you had to be put on atorvastatin versus placebo in blinded fashion. And you had to prove that you're statin intolerant. And about half the patients I sent, literally 50%, couldn't tell the difference between atorvastatin and placebo blinded. I mean, that's wacky, or dysfunctional, or whatever you want to call it, but somehow these patients are suffering. They say they can't take these drugs, but they can't really tell the difference between the placebo and the drug. So something else supratentorial is going on there. But nonetheless, these patients have risk, and we need to address it. Hopefully they'll be able to tolerate these drugs. I mean, that's certainly what we're all hoping. Lamidopide and mipomersen are drugs indicated for homozygous FH. Many of you may not be familiar with them. You get somebody you think has FH, and by think has FH, an adult with an LDL cholesterol above 190, with a family history of premature cardiovascular disease, that's a likely FH patient. Doesn't mean they have it. Send them to a clinical lipidologist. You've got lipidologists out here. Go to lipid.org, put in your zip code, and you can find out where the nearest lipidologist is. Email me. My email is at the beginning and end of this talk. I'll find you a lipidologist nearby. You think you got somebody with FH, get them to a lipidologist to confirm the diagnosis, to do cascade screening of first-degree relatives, and to get patients on the appropriate drugs. These are two very expensive but very useful drugs. And actually, I have an easier time of getting lamidopide and mipomersen approved than I do for branded statins at times. So the drugs are out there. The insurance companies have the money for them as long as you certify that the patient really has FH. So FH is underdiagnosed and the drugs are underutilized. Let's see. Triglycerides as a target. We mentioned that there are 2 new studies out there looking to see if we really should be treating triglycerides as a target. We don't know the answer. We'll have some answers over the next couple of years in the reduce it or strength trials. Combination therapy, there are trials underway with that, and again, combination therapy at times falls by the wayside, particularly with the ACC-AHA guidelines, but combination therapy, there's some preliminary evidence indicating that it works from randomized clinical trial data. Certainly pathophysiologically, it makes a lot of sense to use combination therapy for appropriate patients. Insulin-resistant dyslipidemia, again, many patients out there have a fairly low LDL cholesterol, but it's because their particles are small. They could be swimming in a tidal wave of small, dense LDL particles, but you're not going to know they have it unless you count the particles. So we need to have a renewed emphasis on insulin-resistant dyslipidemias. HDL manipulation, we're not about increasing HDL cholesterol. We're about making a better HDL particle. Maybe the CETP inhibitors will do this. Maybe we'll get some new fibrate data, already some very suggestive preliminary data that fibrates improve HDL functionality. This is the next frontier in lipid management. And those meds, the CETP inhibitors, the first couple ones failed. Other ones are out there that appear to have less off-target lipid effects. The trials are still underway. Nobody's talking about them much anymore, but I have a sneaking suspicion that they're going to work. They do lower ApoB dramatically. So anything that reduces LDL particles should reduce risk. So I'm really cautiously optimistic about this, and I hope we'll hear some more about it. Now, we could do one of two things. I had some extra. We can end now and do questions, or which is what we can do. Okay, I didn't know what time it is. I had a few more slides about statin intolerance, but let me just go to the end and finish up. And I had a slide very similar to what Dr. Kopecky showed. Where do we intervene here? Traditionally, I'll get this right eventually. Traditionally, the patient comes in at a late stage of disease, where they have heart failure, sudden death, acute MI. Obviously, we want to do primordial and primary prevention and intervene much earlier in the process, and we have the tools to do that. Here's the sunset at Cannon Beach, Oregon, one of my favorite places out here on the West Coast. So some of my take-home bullets are, don't be a lipid queen, ladies. Be a lipoprotein warrior, okay, or warrioress. So count lipoproteins in your patients. Make sure that the lipoproteins are at goal and not just rely upon 1970s lipid panels. So treat at least to both LDL-C and non-HDL-C targets all day, every day. Prevent the disease. Don't just focus on preventing events. Don't settle for unacceptably high residual risk on statin therapy. We're only reducing 1/3 of events with statin monotherapy. And I'm a big fan, in general, of higher protein, low carb approaches to treating insulin resistance. And I'm sure many of you in the room might have some questions about that. So thanks very much for having me here. Here's my email if you ever want to contact me about any of this stuff. So thanks.
Thank you. Okay. Every time we have a lipid speaker, I come away more confused.
I know. It
If I have to take the cardiology board exam today, and they ask me about carotid intima media thickness, it is a class 3 recommendation, which means not recommended. And here we're hearing that carotid intima media. So you take these two guidelines, and I don't know why we can't get along.
Right. I mean, there's more commonality than there are differences. There's philosophical differences, in terms of the reliance only on randomized clinical trial data versus the NLA recommendations, not guidelines. I've had that pounded into me often enough. I try not to say guideline. But, I think the commonality between the two is, an emphasis on lifestyle change first, pharmacology second, figuring out ways to assess risk. I mean, there's many different ways to assess risk. The carotid IMT, that's a debatable point. Cardiologists, I know in general, haven't liked carotid IMT for whatever reason. But the data is somewhat controversial. What is coronary calcium's?
Well, coronary calcium score is given a nod.
Is given a nod,
ApoB was not given a nod.
Right.
C-reactive protein was given a nod. ABI was given a nod. So...
Yeah, so there are some differences here. Absolutely. I hope I've tried to give you a flavor for the fact that this is a lipoprotein disease rather than a lipid disease. And I think we have the tools where all of it, we can probably both agree on non-HDL cholesterol.
Yes.
I think both camps agree on that. And that's something that's totally inexpensive. It just takes a second to do. Again, it's something new that patients haven't heard of, so it can give you something to focus on with patients. And it does identify residual risk. Yes?
Fantastic.
Bioidentical hormone. Well, I can tell you, NAMS, the North American Menopause Society, has a very fixed stance on that. I use bioidentical hormones, as in 17-beta estradiol and micronized progesterone, but I use only FDA-approved products. So the bioidentical hormone world tends to mean, I'm not sure if you're using that term to mean non-FDA approved, which I certainly would not advocate the use whatsoever of any quote, non-FDA approved bioidentical hormones. That said, since these are largely topical, right, that's what you're talking about, topical estrogen does not affect lipid lipoprotein parameters hardly at all. Oral estrogen, the easiest consult I get is high trigs, the woman is on oral estrogen, and we take them off the oral estrogen, we put them on a topical form, the triglycerides plummet back to normal, everybody's happy. So bioidentical hormones, as far as I know, are not going to have any negative lipid effects as long as they're used topically. I assume that's what you mean. Yeah. So very very benign effects. Yes.
Yeah, I'm a stroke coordinator, and the recommendation if the LDLs are greater than 100, then they send them home on a statin. But what I've noticed is that if we're 100% compliant on that, and then with the high intensity statins, we're 28%.
I missed the beginning of what you said. You're coordinator for what?
Stroke.
Oh, stroke. Okay. So you're talking secondary prevention, because that's important to know where you're coming from. So you're saying compliance with high-intensity statins is much less. Probably, I mean, I would assume it's because of statin intolerance, right? You know, and that's, we could talk a moment about statin intolerance if you want. Is that what people would like to talk about? Yeah. So I mean, as I said, this is a big problem. It prevents our patients from taking a proven effective strategy. What do? You know, many of the statin intolerant patients who come in have only been on 1 or 2 statins. So take a good history. You know, find out what they've been on. Often they haven't been on some of the more obscure statins, such as fluvastatin or pitavastatin, statins that offer some slightly different properties than the statins that most patients are sent home on, like atorvastatin or rosuvastatin. So take a good history. Try an alternative statin. A lot of patients can tolerate that. Make sure that the patients have normal thyroid function. Try to make sure that their vitamin D status is reasonable. You know, there's some evidence that maybe vitamin D status could affect the incidence of statin adherence and statin intolerance. If you've been through all of that and you've exhausted standard statin therapy, you can think about using interval dose statin therapy. A lot of patients can tolerate a Monday, Wednesday, Friday dose of low-dose, longer-acting statin, for example, rosuvastatin, pitavastatin, or atorvastatin. You know, these are long-acting statins. You could try them on a Monday, Wednesday, Friday, low dose, like 5 milligrams of rosuvastatin, 1 milligram of pitavastatin, and maybe 10 of atorvastatin. Try that. A lot of patients can tolerate that. And then you can slowly try to build up the dosing of the statin, but maintain the spacing of the dosing. So in other words, I'll try to go up a little higher, maybe to 10 milligrams of rosuvastatin on Monday, Wednesday, Friday, et cetera, next. You can use extender drugs like ezetimibe or colesevelam, which are really underutilized in this country. Use them as extender drugs on top of your baby dose of statin. You know, those are some practical strategies. Obviously, we have new drugs which are about to hit the market, which will really help us, I think, in terms of the PCSK9 inhibitors. But I hope that gives you a little bit of a flavor of the way a lipidologist looks at these interval doses of statins. Of course, are off-label, but again, there's actually a small study that AstraZeneca did looking at interval dose rosuvastatin, 10 milligrams Monday, Wednesday, Friday, and you got 30% LDL-C reductions, which is not bad. You add some ezetimibe to that, you're going to get even more. So, you know, you really need to devote a lot of time and effort to these patients. You need to validate their concerns. You know, I don't mean to be cavalier and say some of these people are wacko, but I mean, obviously they have pain, they're unable to take their meds. I mean, you need to sit down and talk with them and validate their concerns.
Questions? Yes.
I was just wondering if you could comment on the discussions that are out there about the role of cholesterol particles in neurogenesis and the effect of increased neurodegenerative diseases with ultra-low cholesterol levels.
So the question was correlation between LDL particle counts and neurodegenerative diseases, and I really can't comment on that very much at all, just because I don't know a lot about that topic. Come up to me later and you can inform me. I'm guessing you're inferring that low LDL particle counts are somehow correlated with neurodegenerative diseases. Yeah, and I would be leery of that data. I mean, you got to show me some. I tell you, patients are coming into me and saying, I heard Dr. Oz or somebody else on some other TV, Dr. Charlatan, I said that statins are bad for me because they're going to make me demented. You guys getting patients? That happened to me twice yesterday. You know, and I say, look, you know, statins don't cause dementia. They may, and I'm not even sure if I believe this, they may in some cases cause a reversible cognitive dysfunction. You know, that's kind of within the realm of reason, although the data is not great to support that. You're not going to get dementia from a statin. Matter of fact, statins seem to be associated with reduced dementia, not increased dementia, particularly the multi-infarct vascular kind of dementia.
At what level of LDL do you get concerned? Low level?
I'm not really
30?
concerned. I'm all about the particles. Because I have patients with the total cholesterol of 80, and their particle counts are barely low enough to where I want them to be. So I don't get too concerned at all. There's no clinical trial data supporting problems. Yeah, I'm really not that concerned. Yeah.